I'd like to thank you for the invitation to come along and talk about telehealth and what the College of Physicians have done with respect to that. I operate as a Director of Neurosciences, running a regional stroke unit at Barwon Health, the Geelong Hospital, and clearly have an interest in telemedicine and regional healthcare in general. And it's a fraught area for us in terms of delivering services. The College of Physicians, what I'm going to talk about, I'll go through what the College of Physicians Telehealth Support Project actually did, why it was convened, what its outcomes were. And then I'm going to just briefly touch at the very end on the impact it may have on regional workforce, and also discuss maybe some ideas as to whether or not there's any utility for actually teaching advanced trainees in neurology or other subspecialties or medicine in general using telehealth. I should say all this without prejudice, shouldn't I, just to cover myself? This was an Australian-funded initiative under the auspices of Connecting Health Services with the Future. And it commenced in May 2012 through to June 2013, and it convened an expert panel, what it deemed was an expert panel, I'm not quite sure about that, as a working group. And the primary outcome was to increase the awareness of telehealth and encourage its uptake by physicians and facilitate the implementation of telehealth into clinical practice. Its deliverables to government were guidelines and a continuous practice development module. Now, on the web, there are the details of all of what they did, and I'll just stop this and get into the web. Still there, Firefox. So if you get into the College of Physicians website, this is available. You don't have to log in as a member. You can actually just get access to it. I wish I hadn't done that. This goes through who the people were that were involved, that formed the working group. Interestingly, they were a conglomerate of regionally based physicians in various subspecialties. Paediatricians, both in central Sydney and also up in Townsville. There was a bioethicist, Paul Talman, sat on the committee, and then other people who had an interest in delivering care to remote and regional parts of Australia. Interestingly, there was no lawyer, which probably was an oversight. They then sought advice from a whole body of other people in terms of developing their guidelines. They then came up with a set of guidelines on how to, which around guidelines of what telehealth means, practical tips on how to operate in telehealth, and then they produced this education module, which you can go into, and you get continuous practice improvement, which goes to your credentialing with the college if you do it. Guidelines and practical tips. So basically, they were how to operate in the telehealth environment, and they produced a whole set of guidelines covering the basic requirements of conducting telehealth consultations and guidance on privacy and confidentiality and consent. There was quite a discussion about, do you need to consent a patient that they're undergoing a telehealth consultation? You certainly need to inform them, but do you need written consent? And there were varying opinions regarding this. I don't think it's a resolved position. It was deemed that this was a normal consultation Did you reasonably get patients to sign consent to enter a consultation? No, you didn't. It was implied, but it still needs to. I think this needs to be. This is an unresolved issue, and this needs further discussion and certainly advice. There was huge discussion on commencing telehealth in terms of patient selection and where to provide telehealth services to. Patient selection in terms of patient complexity. Do you see a new patient with a complex medical history with lots of interacting comorbidities via telehealth? Is there something that telehealth does that would make you less effective as a practicing clinician? Then the technological requirements, the basic infrastructure that you require, how that's maintained, how you troubleshoot it, and then on to risk management. The practical tips went in and do go into more detail about when telehealth is appropriate, when it may not be appropriate, the relationships with other healthcare providers that you're delivering telehealth to, and I'll have something to say about that at the end, and also production setup. This is a different set of consultation requirements. You actually have to have some idea of what you look like over a telehealth consultation. That is, what's behind you. Are you looking at the camera? Because if you're looking at a camera, or you're looking at the patient which takes your eye off a camera coming in, you don't have eye contact. That is an absolute no-no during interpersonal relationships when you're building them. You must have eye contact. And if the telehealth setup that you've got takes your eye contact away so that you're looking at a screen because you can see the patient there, but the camera's looking at you there, it's a disinterested appearance. You look like you're not engaged in the consultation. So these are nuances that you would not necessarily be aware of when you initially start up telehealth. So the production of your telehealth consultation needs some attention. The CPD module is quite extensive. It's got a number of cases and case scenarios that take you through telehealth. It talks about MBS items and scheduling of patients, how you should schedule, how you should set up your consultative process. Your room setup, lighting, sound, camera and furniture are also discussed, again production values, and goes through a number of case studies with videos. It also discusses how to build a business case for telehealth. That is, if you're within an organisation or you're not operating as a private practitioner, but if you're operating as a public physician in an outpatient setting and you want to do clinical neurosciences consultations to your regional hospitals that are sending you patients for consultation, how to develop a business case to go back to your hospital to say, well, we need this requires some funding input. This requires you to actually buy into the fact that we want to do this. This is an efficient way of handling patients. Understanding that the pressures on all health services are there are more patients than we have time available to see. Yes, we can make improvements with efficiencies like this. This can actually make your practice much more efficient. You can see more patients and do more clinical work, but you need to build that argument with your organisation. It also enables you to, or teaches you how to do an audit to help evaluate the effectiveness of your telehealth performance and improve its service. And also getting patients to evaluate what they thought, whether they were satisfied with the telehealth consultation, and to use that in your audit process to see whether in fact this is an effective way to interact. We don't do it a lot in normal consultations, but this was sort of best practice, I suppose, as it were. So that's under the education. So what we have is the website, telehealth case studies, an information kit, and telehealth fact sheets that are available for the clinicians to download to use in their practice if they're engaging in telehealth. I now want to flip across to a little bit of what we have done in Barwon Health and the pressures for doing this. So in 2009, we were a regional hospital not doing thrombolysis, which would be deemed best practice in stroke management for anybody presenting within 3.5 hours of the stroke. We had a number of neurologists that were within 15 minutes of the hospital and other neurologists that were at a distance of about 40 minutes to 45 minutes from the hospital. Time-dependent therapy, time matters, time is brain. So we initially investigated the feasibility of using direct links with our ED department using a telehealth setup. And what we used there, the southwest of Victoria has its own internet through the Southwestern Area Regional Health Network. So it has its own internet, which is outside the normal internet. It's got its own wiring and spine. So when you're on that network, you're in a secure network. It works relatively well and it's very stable. We were able to set up a laptop that had the ability to dial in through the SWA system using a 3G modem at the remote site into the emergency department to give advice. So patients were asked, do you mind if the consultant conducts a consultation with you over the internet now? And if the answer to that was, I'm a bit unsure about that, the consultant got in the car and drove in and lost the 45 minutes. We had no refusals to do that. The advantage of this system was you could move the camera around, you could zoom in. The camera in the emergency department gave you the resolution to be able to look down somebody's throat and actually see their palate move. You were able to pan to the patient's relatives, and literally it was like you were in a consulting room. It was very flexible. It had some problems in terms of the technology wasn't quite up to today's standards, but nonetheless you could do that. You could look at the radiology and you could conduct a consultation, and it took around about 20 minutes to do that from the time that you were called, dialing in, starting an ED consultation, to being able to direct the registrar, because at that stage we didn't have advanced trainees on call all the time, so there was no advanced trainee per se in the hospital, and it gave us some reassurance that yes, this was a stroke and was appropriate for thrombolysis. We used that for the implementation phase of thrombolysis until we got very sure about thrombolysis, and now we wouldn't use it at all. We don't require using telehealth to do this. We have advanced trainees 24/7 that can get into the emergency department at a moment's notice and can discuss with the neurologist, and we can see the radiology, which is the end point that we matter. We still attend, but we say yes before we actually get in there. So there's those 40 minutes aren't lost for the more remote neurologists. There was huge, this was a very difficult phase in deploying acute thrombolysis, but this is where telehealth facilitated us to do this more quickly because we didn't necessarily have the workforce. And then from 2012 onwards, we've looked at consultative telehealth using both Skype and our own internal SWA system, which is a Polycom system. Not all neurologists clearly want to do that. In fact, only 3 out of 9 neurologists want to do telehealth consultations. The others are very wary about engaging in this system for their own reasons. So our experience, I should say, is that we got started. We certainly got our regional patients involved. That is, the demand isn't from the healthcare providers. The demand actually is from the patients. When you've got patients driving 3.5 hours for a 20-minute or 15-minute review consultation, they will tell you, yes, I would much rather being able to do this via Skype, almost universally. I've never had a patient say, look, I'd rather come up. Sorry, I have. A lady wanted to do shopping in Geelong from Warrnambool. She said, look, it's okay. I'm happy to come up because I'll go shopping. But other than that, patients want the best care they can get delivered most conveniently. If you said to them, look, it's probably a really dodgy system and I don't think you're going to get best care, they will drive the distance. But if you feel that you can deliver a competent consultation over Skype and they accept your advice on that, then they will universally want this system. So it's patient-driven. The other part that we found interesting was that a lot of the primary care physicians, the general practitioners, were not ready and not willing to do this type of consultative medicine. And it took a long time to get a couple of practices involved in doing this type of consultative medicine. So there was a real lag. But it was driven eventually not by the consultants, not by the health services, not by the specialists. It was driven by the patients. The patients demanded the service. This is available, I want to do it. And it was through that it actually evolved. So in doing this, it is very important for the consultant or the person on either end to read the notes, the referral letter and imaging and all the information prior to engaging in the consultation. You have to do about a 10 to 15 minute read of all the notes, of all the results, of all the imaging before you actually get on to the interview. You must go prepared. You can't fiddle around while you're actually performing this consultation. You have to be aware that it's not just you anymore in your time constraints, but general practitioners have a different clock. It's more a legal clock. It's more 6 minutes. It's not 45 or 30 minutes. It's a much faster clock, and they have absolute time constraints on their ability to sit in on these consultations, and you must be aware of that. The next, for our experience, was the selection of which type of patients. We did not begin this process by seeing new patients. Not while we were learning how to fiddle with the technology or to interview somebody over a screen. And so we started with simple reviews. People that actually didn't need to physically be present, that we wouldn't need to examine, often headaches, seizure disorders, somebody who needs anticonvulsant control, and that's a clinical narrative. That doesn't require you, on the vast majority of cases, to perform an examination. So the simplest patient profile you can find and it works out most convenient for the patient. And then to allow complexity of case complexity to evolve as your, I won't say competency, but you're comfortable. You become more comfortable with doing this. This is initially a very strange environment to start doing consultations with. So I actually think it's different. I actually think it changes some of the dynamics of the normal consultation. The last slide I want to go over in the last couple of minutes is the telehealth landscape. This came out through the telehealth working group, particularly with paediatricians, and I had an example not more than an hour before I came up to this talk of what this does. So is it just a business opportunity? Will people see this as a business opportunity? You know, we can pipe in the Melbourne expert to the poor regional people that need the help. And that's it. Terrific. We can give them an opinion and we can exit. And one of the consultants in Townsville said this will be a disaster for the paediatric workforce in North Queensland, because these guys will come in, they have no relationship with us or our network or our allied health or our infrastructure. They give an opinion and they'll leave. That is, it's all done virtually. But we're then expected to deliver their opinion. We're not involved in getting the opinion. We're not involved in any part of that consultation. And it also takes away the work that would get the next consultant physically into the region. So these were announced as huge concerns on their behalf. So today, before I came down, I received a letter from a neurological consultative service who'd done a video consult with a patient in Portland, who'd sent a letter to our registrar asking them to admit them to the Geelong hospital and do these investigations. No diagnosis, no call, just a letter. Now that is mind-bending when, I mean, that, I just don't know where to go with that sort of medicine. That is the antithesis to what you're actually trying to achieve. So again, sorry? It was a private neurological service? I'm not sure. I won't say any more because it'll become obvious. But it's sort of, now we know in the regions that workforce is everything. It's taken us 10 years to stabilise our workforce in Geelong, to the point now where we can expand that workforce into the regions. So telehealth has a role, but it's not a panacea. And if you don't obey networks and referral patterns for escalation of complexity, then I don't think it has a utility. I mean, seriously, if I want an opinion, I'll go to the Mayo Clinic. If that's what it comes to, if I want the elite opinion, but if I want health care, I need to be part of a network that can look after the different components of that health care as it escalates up, requiring a quaternary or tertiary hospital. So these are really important issues when you design a model of care and a new way of consulting in medicine. It's not just about giving an opinion, it's about all the other things that go with that, the allied health components, the local community centres, the local primary physicians, they've all got to be involved. And this service has got to be part of those collegiate networks that exist. And if they don't exist, they need to be developed. The software, of course, is an issue. Privacy, confidentiality. There are multiple vendors. There are nuances between the two. There's a cost impost. But there's one truth. The most accessible and that's universally accessible and the lowest cost will always win. The issues of consent and security, I think, are ongoing. I don't think they've been resolved at all. I think that I don't think we've had any, well, we certainly haven't any test cases of this, but you know, whether this needs to be further evolved, I'm unsure of. But I'd like to finish on the idea that telehealth has an absolute role both in stroke medicine, acute stroke medicine, and consultative medicine. However, I don't believe that you need to be very cognizant of the intercollegiate relationships that exist and those people's availability along the chain of healthcare, and they can't be ignored. They are the foundation on which I think you build telehealth, and to just have independent phone-in consultations or telehealth-in consultations and then remove and have no existing relationship with the region, I don't think it's going to work, and I think it's going to lead to significant issues in the future. So I'd like to finish it there. The first half is what the college have done, a CPD module. You can get credentialed on that CPD module. If you complete it, you claim it against your continuous practice development. It's a useful site. It has been well thought through. And then the actual practice of it, I think, adds another layer of complexity altogether. And I think we're really just at the very beginning of the utility of this type of technology and where it fits in clinical practice. I think that there is a lot to be decided. Thank you.
One of the key issues that we've certainly encountered in our stroke telemedicine work in Victoria is an issue of workforce. and we all work in hospitals, and which is a pretty siloed environment, but we're trying to deliver a service that's obviously much more widespread. But we end up, probably like yourself and your group in Barwon South West, you end up doing a lot of that outside or in addition to your other routine activities. I guess I'd be interested to know whether the college has thought through the issues of workforce and changing the workforce dynamic as to, you know, a more broader model where people deliver their skills back to the health service as opposed to delivering their skills within our hospital silos.
Yeah, no, look, I don't think that that has been clearly sorted, Chris. That's one of the concerns I have overall. I don't think that that's been really well thought out. But, you know, regional, if you want to deliver healthcare to give equity of access to regional Victorians, because there's enormous inequity. I mean, if you happen to be in Paran and have a heart attack or carcinoma of the prostate, your outcome is significantly better than if you're in Gundawindi North. And these things should be designed to equalise that equity of access and give regional patients the same health options as what those people in metropolitan Melbourne have. And one of the ways that you will not do that is by diluting the workforce from the regions. I mean, do we need doctors in regional Victoria, or can we do it all via this technology? And the answer to that is clearly that's absurd. Amanda.
I'm loud, so I'm in the microphone. It's a fantastic process of seeing telehealth rolled out across Australia, because I think it has a lot to offer. But as you're right, we're still trying to work out the nuances of where it fits. Having visited the guys who did the Tempest project in Germany, they took junior consultants, people writing up their PhDs, and sat in a room and they took all the phone calls. So basically, you then, as Chris is saying, you then pay workforce to sit and give that expert advice to a wider region of people. Because at the moment, we're just adding it onto our already filled timetables, and part of the problem then is it's going to be that the workforce will fall over because they can't do all the work that they're scheduled to do here, plus all the telehealth consults. So did the health department have any concept of how they're going to fund a realistic ongoing model?
Look, this was a college-based, we didn't have anything to do with the federal government, apart from deliverables for the project, and I have no idea whether they've thought that through. I'm also slightly amazed at the process of giving a Medicare provider number for a rebate for a telehealth consultation out of the blue with no logical... I mean, I would hold them liable. That is, they created the facility to do this and then basically said, well, knock yourselves out. You sort out the detail of how it should be done without any... I mean, there were rules about what constituted a telehealth consultation, but it's a very crude lever to pull, and then a lot of responsibility and thinking has to go on at the operational levels to actually get it deployed. So it's been a very interesting process.
From your experience, if you had to put a business model up for it, what do you think the 2 or 3 fundamentals may be?
That you do telehealth combined with physical presence, that you invest and you create workforce in the sites that you're telehealth toing. That is, you must build the people on the ground. The people matter. I mean, especially in medicine, it is about people. Your workforce is absolutely everything. And this is not the panacea for an absent workforce. You still have to go ahead and build the workforce. You should do this under... The other thing is the technology of it. Until the vendors provide programs that are idiot-proof and robust, and they don't, you know, they don't go offline mid-consultation. So I don't think the technology, broadband would have probably made a change, will make a change to that. So that's the other thing, is the technology need, and you need to go somewhere where when it doesn't work, that's like instant. So it does need to really emanate from major healthcare providers. I don't think me sitting in my, you know, as a separate entity to a major institution is probably the best way to do it.
I'm just interested in the your idea of regional things. In Queensland, we're sort of struggling with this, as you can imagine, and I see telehealth as perhaps an ideal way to support and bolster regional providers. You know, if we've only got one stroke specialist in Mackay, for example, how do you sustain a 24-hour lysis service when they're the only person within a 500-kilometre radius, for example, or Townsville might have 3 or something? It sounds very appealing, but it's incredibly hard to organise at a distance. Are you aware of where it's been done in other subspecialty areas or for other things, where you have like an integrated system where you support sole providers after hours and holidays and things?
In Queensland, in cancer. So one of the people that sat on the committee is an oncologist who was delivering chemotherapy via telehealth. So again, you know, he figured I can do this if I've got a registrar out there and I can telehealth to the patient. I've got all their data. I know what drugs I'm going to give. These are the infusion rates. That's viable. So people could be delivered their chemotherapy locally. So these are the things where you've got to really scale it to things that, you know, where you're reducing your risk exposure. And in those circumstances, it's worked very well and provided the people of Mount Isa with a virtual oncology service, which they were travelling to Brisbane for.
Okay, well, thanks for that, Paul. And we'll break for afternoon tea and come back for some more telemedicine discussions.